Hello everyone, welcome to Medical MCQs and Lecture. Today we are going to talk about jaundice. In the last video, we talked about bilirubin metabolism. So let's jump into this topic of jaundice. How can we define jaundice? Jaundice is yellowish discoloration of skin, mucous membrane, and sclera due to increase bilirubin in our blood, that is hyperbilirubinemia. Normal serum level of bilirubin is up to 1 mg per deciliter. However, it can rise up to 1 to 2 milligram per deciliter without showing any clinical sign of jaundice, called as latent jaundice. At the same time, overt jaundice is something when jaundice can be detected clinically with serum level of bilirubin more than 2 milligram per deciliter. Jaundice can be classified into prehepatic, hepatic, and posthepatic. Talking about prehepatic jaundice, it is when liver is not involved. We know that bilirubin comes from RBC. So when there is excessive hemolysis, due to hemolytic anemia, sickle cell anemia, hereditary spherocytosis, and infections like malaria that leads to hemolysis, there is excessive bilirubin production from RBC. Now, our liver is normal, okay, but the pathology behind prehepatic jaundice is hepatocyte gets saturated due to its limit. It will conjugate bilirubin up to its maximum capacity. After that, it is not able to take bilirubin inside it and conjugate it. That's why there is increased of unconjugated bilirubin in circulation. Second one is hepatic jaundice. It is when liver is primarily involved. So, due to infections causing hepatitis, alcoholic hepatitis, and some congenital disorders that are Crigler-Najjar syndrome, Dubin-Johnson syndrome, and Rotor syndrome. It leads to increase in both conjugated and unconjugated bilirubin. It happens so because when liver injury occurs due to infection or alcohol, the cell lysed and the content from inside leaks into circulation. So here we have conjugated bilirubin that leaks into circulation, and due to injury, after a time, liver is not able to conjugate according to its capacity. So there is rise in both conjugated and unconjugated bilirubin. So in Crigler-Najjar syndrome, there is deficiency of uridine glucuronide transferase enzyme that is responsible for conjugation of bilirubin. So when this enzyme is deficient, it is natural that bilirubin won't be conjugated. Here there is rise of unconjugated bilirubin. However, the cause is hepatocellular. Talking about post-hepatic jaundice, it is also called as obstructive jaundice. Here there is obstruction in the flow of bile. It can be either in the intrahepatic right and left hepatic duct, common hepatic duct, common bile duct, or so this jaundice is mainly because of obstructions. It can be either at this level, or this level, or at this level. So what are the cause of this obstruction? It can be any stone, cyst, carcinomas, basically tumor, or stricture. And there's something called as Mirizi syndrome, when there is a stone in the cystic duct large enough to obstruct the flow of bile, then it is known as Mirizi syndromes. These are cause of post-hepatic jaundice or obstructive jaundice. In obstructive jaundice, there is rise in conjugated bilirubin. Since bilirubin has been conjugated, but during its flow it was not given its way and it regurgitated back into liver and then into circulation. Here stool is clay color and urine is dark color. Urine is dark color here because of excessive conjugated bilirubin going into circulation and then filtering through kidney. However, stool is clay color because due to this obstruction, this conjugated bilirubin was not able to go into intestine and gives feces its color, which is the role of stercobilin, a product formed from bilirubin. This was all about basics of jaundice. In the next video, we'll be talking more on investigations and clinical signs of different kinds of jaundice. Thank you, everyone.